Dinesh, we are set, no? I'll just give a
Nice one.
short intro and then we'll start.
Sure, ma'am.
Good evening, all. Welcome back to next episode of our Journal Club for the month of July. And again, it is Dinesh. After the last success, we hope this one is also another benchmark for us. This time, the topic is viral encephalitis, which we encounter so frequently. One of the commonest causes is also herpes simplex, and with the predilection of the area of the brain which it affects, it's very common to have speech deficits. So, this is an article which looks at how to reduce the speech deficit. We have to find out whether we should implement in our daily lives or not. Over to you, Dinesh. Thank you.
Yes, ma'am. Good evening, all. As ma'am said, today we are going to have a discussion on the safety and efficacy of the dexamethasone in adults with HSV encephalitis. Myself, Dinesh, trainee in Kamachi Memorial Hospital, and then my moderator is my head of the department, Dr. Devachandran. So, how we are going to, I'm not able to, okay. So, how we are going to have this journal club is first we will be having a brief discussion about what is HSV encephalitis and then what are the pathophysiology, why steroids were thought of, and then what were the previous studies tells about the same, and then the brief overview of the what the study all about, and then we will start doing a CASP checklist. So to start with, if you talk about a HSV encephalitis, it is one of the rare disease. If you see the incidence is 1 in 2 lakh 50,000 to 5 lakh per year. And the before acyclovir, the mortality is close to 70%, and thanks to the acyclovir for bringing down the mortality to somewhere around 5 to 10%. And even though acyclovir significantly reduces the mortality, if you see the morbidity remains high. The less than 20% of the patients return to work. Almost 48% remain moderate to severely disabled. Uh, what is the pathophysiology or what causes the additional brain injuries? It is not only the direct viral-related destruction of the neurons. It is also the immune-mediated pathology that also causes additional neuronal injury. The studies have shown that higher CSF pro-inflammatory chemokines are associated with worse outcome. And as ma'am was saying, the HSV is known to affect the temporal lobe, and the temporal lobe is associated with the verbal memory. The studies have shown that degree of the temporal lobe swelling on the MRI correlates directly with the severity of the verbal memory impairment. It is not only that, the relapse also occurs in almost 5 to 27% of the people. Predominantly, it was immune mediated. And then what is the role of corticosteroids? As we discussed, the pathophysiology is based on the inflammatory response, and we are aware of the use of steroids in the steroids is a proven treatment in a TB and bacterial meningitis. So people thought of why can't we use the steroids for HSV encephalitis, since the pathophysiology is also related to the high inflammatory state. And also, not only that, HSV encephalitis can closely mimic autoimmune encephalitis, for which the treatment remains steroids. But the fear factor for using steroids in HSV encephalitis is because steroids can cause uncontrolled viral replication, which in turn worsens the outcome in HSV encephalitis. So this was the key concern. In the UK, the current practice is the steroids are not started until you exclude a HSV by PCR. This is the intro. Previous studies, what it says about role of steroids in HSV encephalitis. One of the RCTs which exactly try to answer the specific question, the gas study, the German trial of acyclovir and corticosteroids in HSV encephalitis. It was a multi-center randomized double-blind placebo-controlled RCT. The interventions are dexamethasone versus placebo. Apart from both group received acyclovir. If you see the entry window, they included less than 5 days from the hospital admission, and if there is a focal neurological deficit is there, it is considered as an entry criteria. They try to look out the modified ranking scale as of their primary outcome at 6 months. Because of the chosen primary outcome, the total numbers they needed to recruit is 372 patients. What happened to the trial is it was stopped prematurely due to the poor recruitment. Uh, they could only recruit 41 patients out of the total 370 odd patients. Even in 41 patients, if you see there were no significant difference in the primary outcome in 6 months. Uh, if you see some of the retrospective studies, it shows some benefit of steroids in HSV encephalitis because the gas trial stopped prematurely, and then some retrospective studies hinted at some benefit of steroids in HSV encephalitis. The specific dex encephalitis design was started. Having said that, uh, in gas, they were not able to recruit the many patients because the HSP as such is a rare disease, and then they were not able to recruit the 376 as they would have liked. How the Dex encephalitis overcome the limitation of the gas trial? If you see, these are the basic differences. In general, what they try to do is their main aim is to recruit what they wanted, so they made some liberalization in various points. If you see the entry window, the Dex template the entry window was broader in terms of less than 7. They have included any features of encephalitis, not only the focal neurologic deficit, any features like a seizure or a psychosis or any kind of features were included as an entry criteria. If you see the primary outcome that we have already discussed, the temporal lobe is involved with the verbal memory. So they have chosen a verbal memory, the disease specific outcome they have chosen, because of which the sample size needed to recruit was only 90. And then the if you see the design, it was a observer blind, and the patients were open. The simple logical reasons is they try to recruit what they wanted. So let me tell, it was one of the first completed RCT in answering a specific question whether the role of dexamethasone in HSV instability. This is how some of the modifications they have done as compared to the gas, so that they were able to recruit or they were able to complete the RCT for this rare disease. Uh, we will slow in next few slides, 2 or 3 slides, we will try to have some overview about what the trial is all about, and then we will move towards the CASP checklist. In general, as we discussed, almost 1,400 people they have screened. uh, if anyone who is CSF HSV PCR positive, they have included, and then all those inclusion and exclusion criteria we will see as that as we move forward. uh, Almost 90 people they have chosen, the 45 in the dexamethasone arm, 45 in the control arm, and then they have collected various data at various points. If you see the baseline, they have collected some data. Day 14 and day 30 they have collected some data, and then they have followed at 26 weeks, and also they have followed at up to 78 weeks. So they have collected various data. The primary outcome was the verbal memory score, and then some of the secondary outcomes they were interested, as we have discussed, dexamethasone might increase the viral increase replication. So they were interested in seeing whether the dexamethasone is increasing the viral replications. How they did is they did a CSF analysis at the second week to see whether the dexamethasone increases the viral replications. These are the one of the outcomes they were interested. The other outcome they were interested in the safety or adverse effects of the dexamethasone, and then also they were also interested in seeing the relapse of the HSV encephalitis. These are some of the important outcomes they were interested. We will see in detail about what are the primary and secondary outcomes as we move forward. Uh, so coming to the primary outcome, how it is just how they actually measured the verbal memory score. Uh, if you see the verbal memory score will be done by a neuropsychologist. It carries a two parts. One is the logical memory, other is the verbal paired associate. Logical memory is nothing but the neuropsychologist will tell a short story, and then patient has to tell the same story in their own words immediately. And also after 30 minutes, some questions are asked relevant to that story, so they have to answer that. So they are checking these two components immediately and also after 30 minutes. Coming to the verbal paired associate, the paired association is nothing but the example is like, for example, if the neuropsychologist will tell some paired associate, doctor stethoscope. If for the doctor the paired associate is paired word is stethoscope, something like that. River, boat, something like that. The paired associate they will keep on telling. In the list of the paired words will be told by a neuropsychologist, and then patient has to tell immediately and also after 30 minutes, with which they will calculate the sum score. So there are four components: the logical memory, the immediate score, and then delayed score; verbal paired associate, immediate score, and late score. So immediate is how much information goes in. Delay is how much is retained. This is where exactly the HSP can damage. With that, the verbal memory score ranges from 40 to 60. The mean score they were calculated somewhere around 100 for a viral for someone who are infected with the viral encephalitis. The mean score expected was somewhere around 84. If the patient dies or the patient were too ill to too sick to perform this kind of verbal outcome, they were given a lowest score of 40. So this is how they have calculated the memory. So coming to we will touch upon the key results of the dexamethasone trial. The primary outcome, the verbal memory at 26 weeks. If you see the dexamethasone group, the mean score is 71, and then control group, the mean score is 69. The adjusted mean difference is 1.77, varying from -9.6 to 13.1, which also includes zero. The p with a p-value of 0.76 is basically, yeah, the statistically no significant difference. The dexamethasone didn't increase or didn't improve the verbal memory in a patient with the proven HSV encephalitis. And then if you see some of the secondary outcomes, they were interested in, there were no increase in the viral replications at the second week if they do a CSF PCR. And then there were no dexamethasone related deaths. Basically, the dexamethasone was well tolerated. And only one thing which we have to remember is the all the relapse happened all in dexamethasone group. Five clinical relapses happened all in the dexamethasone group. But the median the relapse which happens is 24 weeks. This carries some significance, which we will see as we move forward. So the bottom line, what they wanted to say is the dexamethasone definitely didn't improve the verbal outcome, but however, it was safe in terms of it didn't increase the viral replication. There were no treatment related deaths. The bottom line is, if we suspect an encephalitis, any kind of encephalitis, we don't have to worry. We can start steroids early without worrying about dexamethasone is going to increase the viral replication. So we can start even before the CSF HSV PCR. This is what they tried to say. So with that background, we will try to go through the CASP checklist. So first, is the basic study design valid for the RCT? The first question is, did the study address the clearly formulated research question? Definitely the research question is this: the dexamethasone improved the verbal memory at 26 weeks compared with the acyclovir in confirmed HSV encephalitis. Definitely that the study addresses the clear formulated research question, and then they have chosen a verbal memory, which is a kind of disease specific outcome. If we go through the PICO population, as we have discussed, anyone adult of more than 16 years with a proven HSV 1 or 2 PCR in CSF, The intervention is dexamethasone plus acyclovir. The dexamethasone, the dose, the 10 mg QID in 4 days, which they have chosen based on the bacterial meningitis dose, and then comparator is acyclovir alone. The primary outcome, which we have seen, is the verbal memory score. These are the inclusion criteria which we have already discussed. Someone with a confirmed diagnosis or any features of encephalitis with the age of more than 16 will come as an inclusion criteria. Coming to the exclusion criteria, if you see, if someone has received corticosteroids, either oral or injectable, within 30 days, they were excluded. And corticosteroid hypersensitivity, if they are immunosuppressed with this background, or if they have a pre-existing indwelling ventricular device, peptic ulcer disease, if someone is an ART with a rilpivirine regimen, which may have a drug interaction, so they are all become exclusion criteria. So what outcomes they exactly measured? We know the primary outcome which they have measured, and then coming to the secondary outcome, there are a big list of they were interested. They haven't tested only the verbal outcome. If you see the verbal memory, if you see the secondary outcome, they were interested in assessing the visual memory, working memory, processing speed. And then if you see the neuropsychiatry, they were interested in seeing the depression and anxiety scores. And they were also interested in clinical in terms of a need for the HDU and ICU admission, time of the ventilation, time to peak GCS, and that they were interested in disability functions, imaging, the involvement of the temporal lobe, regional volume, quality of life, and then they were also interested in the safety outcome in terms of a detectable CSF PCR at 2 weeks. The second question was the assignment of the participants to the intervention randomized. Yeah, definitely yes. How the randomization was carried out is the 1:1 allocation using a minimization algorithm with a random element was done. The algorithm was hosted on 24-hour secure-based system at the Liverpool Clinical Trial Center. And then local site study teams were able to assess the website to carry out that allocation, but however they couldn't predict what the next assignment is. Coming to the randomization, how they did a randomization is they also use the randomization with the minimization factor. They used these four factor, like age, steroids, GCS, and delay in acyclovir treatment, which individually in turn have prognostic implications of the HSP encephalitis. They made sure that with the kind of minimization factors, that with the algorithm they try to balance group in two groups. So these factors will not be a hindrance. They try to balance both groups with the minimization factors. And then was the allocation sequence concealed? Yes, there was the site times couldn't predict what the next allocation in advance. However, the algorithm independently was checked by a statistician who are otherwise not involved in this trial. So coming to the third question, where all the participants who entered the study are accounted for. For that, we will see the consult trial profile. First, before going into that, first, how they selected the sample size. They estimated, they expected a 10% mortality after they come into the study regarding to the HSV encephalitis. And then second thing is the mean verbal score they anticipated who someone who infected with the HSV encephalitis was somewhere around 84. And then to detect a meaningful difference, they expected at least a 15.5 points will be more than the dexamethasone group have to score at least 15.5 points more than a control group to tell that we can say that there is a clinical meaningful difference is there. With these assumptions, they have calculated at least 36 per group should be there in both in a dexamethasone group and control group. And they also, and with the power of 80 percentage, with the two-sided alpha significance of 0.05, and also with the acceptable 20 percentage attrition rate, at least 45% per group will be needed. So that is how they have chosen a sample size. If you see the consort, almost 1,427 patients were assessed for eligibility. Many were not assessed for the eligibility. predominantly that almost 1200 were not eligible, 59 didn't consent. Ultimately 94 they have randomized, 47 to the dexamethasone group and 47 to the control group. In the dexamethasone group, we have to remember that one person didn't receive, there was some protocol deviation, one person didn't receive dexamethasone. In a control group, patient received dexamethasone in the first 30 days. In a dexamethasone group, 4% withdraw consent before we do a primary outcome assessment. 4 patients were lost to follow. In a control group, 3 patients withdraw before the primary outcome assessment. 2 patients were lost to follow. In a dexamethasone group, 33 completed a primary outcome assessment. 4 died and two were too ill. So for all those 6 patients, the minimum score was of 40 were given. So imputed primary outcome were available for these 6 patients. In a control group, 33 completed a primary outcome assessment. 4 died and 5 were too sick. So the 9 people were given a score of 40. So in a dexamethasone group, 36 were included in the primary analysis. 42 were included in a control group analysis. So almost 81 patient had a primary outcome available. So they analyzed in modified intention to treat analysis. So this is the overall the consent profile. If you see 7 withdraw consent overall, if you compare both dexamethasone and control group, 6 were lost to follow. If you combine 13 by 94, the attrition rate is somewhere around 13.8%, which is within the acceptable range. They anticipated somewhere around 20% attrition allowance were there, which is within the acceptable range. And then 8 died, and then 7 were too sick to give the primary out, do the assessment. So all the 15 were given a score of 40. So this will be important as we move forward. This we have to remember. So the third question, were participants analyzed in the group to which they were randomized? So we have seen all the participants who were all the randomized patients analyzed in the group to which they were allocated by a modified intention to treat analysis. 81 patients had the primary outcome, so they did a modified intention to treat analysis. So was the study stopped early?
Just
Uh,
one
uh,
second, Dinesh.
yes,
Why
ma'am.
is it called modified intention to treat? What is the modification?
Ma'am, the modified intention to treat means those who have the primary outcome, either in the form of the direct or imputed primary outcome, they only will be considered in the analysis, ma'am. If you see the table, uh, the 47 assigned to the dexamethasone and 47 assigned to the control, but only the 39 we had the primary outcome in the dexamethasone group. In a control group, only 42 had the primary outcome available.
Yeah,
In
clarity.
dexamethasone group, 8, this is the 8 we didn't have
Clarified.
a primary outcome. In a control group, 5 didn't have primary outcome. So that's why the
Fine.
modified intention to treat analysis were done, ma'am.
Continue, please.
Can I,
Thank you.
yes, so this also we have discussed that there was some protocol deviation. One patient in a dexamethasone group received no dexamethasone. Only 74% complete the full course of the dexamethasone, that is 10 mg Q6 thoroughly for 4 days. 8 patients in the control group received dexamethasone before randomization, and 4 patients in the control group received dexamethasone after randomization. So this is the some protocol deviation. However, there was a pre-specified sensitive analysis adjusted for pre-morbid comorbidities. They adjusted for a pre-randomized dexamethasone user and also the post-randomization dexamethasone user, and and also they have adjusted for multiple imputation for the missing data. If they the pre-specified sensitive analysis adjusted for these 4 factor also confirm the same result as the modified intention to treat analysis. Even though there was a protocol deviation in terms of dexamethasone, the pre-specified sensitive analysis also confirmed the same result. So coming to the second section, was the study methodologically sound? Were the participants blind to the interventions they were given? Not the participants and the local site teams were aware of the treatment allocation. It was a deliberate pragmatic choice to make sure that they were keen on recruiting the whatever they want to do for this rare disease. However, what they did is there were some steps taken to reduce the performance bias. During every visits by a neuropsychologist reminded the patient before each visit not to discuss any of the treatment related, not to discuss their treatment, like whether they have received dexamethasone or something like that. So this is one thing they have. However, they haven't formally checked whether the actual masking has happened or not, but there were no reports of accidental unmasking throughout the entire trial. And then the second question is whether the investigator blinded to the interventions they were given. If you see, the lead investigators and then statisticians involved in the primary outcome were masked. The radiologist interpreting the MRI imaging were masked, and the independent data and safety monitoring committee were allowed to unblind only for the safety reasons. As we discussed, the local site study teams were aware of the treatment trial. So the investigators were partial blind. Whether the people assessing or analyzing the outcome blinded, so that we have already seen, the assessor, all the neuropsychologists, radiologists, statisticians were fully masked for analyzing the outcome. Were the study groups similar at the start of the RCT? Predominantly, if you see the dexamethasone and control group, all the study groups were similar except for the HSV-2 PCR. Six cases were of the reported HSV-2 PCR were there. All the six were present in the dexamethasone group. However, it is unlikely to affect the final result. So, predominantly, the study groups were similar at the start of the RCT. Did each group receive same level of care apart from the dexamethasone? Yes, they have a clearly defined protocol as per the UK national guidance for the management of viral encephalitis. They have strictly followed the management of viral encephalitis as per the UK national guidelines. And not only the management, even the follow-up study schedule was also same between two groups. Baseline randomization, what are the parameters they have checked? Day 14, 30, 26 weeks, and 78 weeks. The same visit, same assessor, same window, where they were equal in both arms. Basically, the follow-up schedule were. So coming to the what are the as a result section, where the effects of the intervention reported comprehensively is was the power calculation undertaken. This we have already discussed. The anticipated 10% mortality, they have anticipated the 10% mortality. The mean verbal score expected was somewhere around 84.8. And then to detect a, meaningful difference, at least the 15.5 point difference should be there. And then with the 80% power with the alpha of 0.05 with the expected dropout of 20%, the sample size they have chosen is 45 per group. And then ultimately, how the sum of the last two follow up the missing data, and ultimately 81 they were able to analyze as per modified intention to treat. And which statistical tests were used for the primary outcome and cognitive outcomes? Because of the continuous data, the linear regressions test were used. For the binary outcomes like epilepsy, the need for the HDU, the logistic regressions were used. For the time to event outcomes, Kaplan-Meier curve, log-rank test, and Cox proportional hazards model were used. And for all the continuous outcomes, adjusted mean difference were given. For the binary outcomes, odds ratio were given. Hazards ratio were given for the Kaplan-Meier curve for time to event. So all the effects were given with the 95% confidence interval, which were reported for both groups at 28 weeks and also at 78 weeks. And the pre-specified sensitive analysis that also we have discussed, they adjusted for four parameters: pre-morbid memory, and they have excluded a pre-randomization steroid user. They have excluded a post-randomization extra user or crossover control regarding a DEXA, and they have also used a multiple imputations for the two sick patients or dead patients. Coming to the missing data, how the missing data were handled. This also we have discussed. Almost seven withdraw consent, six lost to follow up. The attrition rate were within the allowable 20% range. and then those eight died, and the seven were too sick to assess, and they were given a score of a 10, 40. The multiple imputation sensitive analysis also confirmed the same result. As far as the bias is concerned, for the selection bias, they try to overcome with the minimization randomization with the concealed allocation. For the detection bias, the single masked neuropsychologist and radiologists and statisticians were masked. For that reason, they have used the multiple imputation with the modified intention to treat analysis. And then coming to the next question, was the precision of the estimate of the treatment effect reported? This also we have discussed. The mean score is 71 in DEXA and 69 in control, with the confidence interval were wide, which also includes 0 with a p-value of 0.76. So which was not statistically significant in the primary outcome. So coming to the post hoc analysis, after they got the result, they were seeing the trend. The key finding is, for every day of delay in starting the dexamethasone, the verbal memory score fell by at least 5 for each day of delay in the starting dexamethasone, which was statistically significant. But again, you have to remember that this key finding holds true even after adjusting for time to acyclovir, age, GCS at admission, and prior steroid use. But if you see closely, the dexamethasone was given, the median day for giving dexamethasone is 7 days after admission. Almost 18% patient received dexamethasone after 7 days, which is after the peak inflammatory response. The peak inflammatory response, which we expect, is usually 48 to 72 hours. So this is one thing you have to remember. And then also, since how to interpret this result? This is a post hoc analysis. This is exploratory in nature. So it should be viewed as a hypothesis generating only. So the hypothesis generate with this, what they conclude is, probably late enrollment might have masked the true early benefit. This might become a hypothesis generating one. Probably in the future studies, the dexamethasone, the future studies should involve the early use of dexamethasone. So this is what we have to interpret with this kind of with this post hoc analysis. Coming to the secondary outcome, all the secondary outcome, none of the secondary outcome were statistically significant, be it in form of the neuropsychology outcome, clinical outcome, quality of life, and also the safety parameter. This safety finding also, which we have discussed, at the 2 weeks, dexamethasone didn't impair viral clearance, which is a kind of a safety mark. So what the clinical point is, we can corticosteroids can be safely started in a suspected encephalitis even before HSV has been excluded by the PCR. So coming to the serious adverse effect, if you see, there are no real differences between dexamethasone and control group. Only two patients had a thrombotic risk both in dexamethasone, that is understandable. One in DVT, one PE, both in dexamethasone only. Uh, so there were no real no differences in terms of serious adverse events between a dexamethasone and control group, which is kind of giving a thing that dexamethasone was well tolerated. Coming to the relapses and clinical implications, uh, almost 5 clinical relapses happened, all in the dexamethasone group, and the median onset for the clinical relapse is 24 weeks after randomization. This needs address. If you see, usually the relapse happens, the post HSV encephalitis, usually it happens somewhere around 3 to 8 weeks after the HSV encephalitis. In all the 5 clinical relapses, out of 5, two were NMDR positivity. How they check the NMDR positivities? They checked that only 2 times. One at second week, one at uh, 26 weeks. This also we have to keep in mind. This specific point related to autoimmune encephalitis we will discuss in some of limitations or appraisal summary. This we will discuss about the the study related to autoimmune encephalitis we will discuss in the appraisal summary. So the coming to the results, can the results be applied to a local population? Definitely yes, because it was a pragmatic real world cohort, a multicentral trial and then both sexes were well presented, and then the standard guidelines were followed. The outcome which were met because the HSP encephalitis was associated with a significant morbidity. The disease specific outcomes were chosen in terms of a verbal memory, a return to work, cognition, disability. All those things were reasonable outcomes. And one caveat we have to remember is if you see race and ethnicity has independently can influence the encephalitis outcome. Predominantly in this group, almost 90 to 93% were white people. This also we have to keep in mind. And then they have excluded the immunocompromised host and under 18 people. This also we have to keep in mind. Would the intervention provide a greater value than the existing intervention? No, dexamethasone didn't improve the verbal memory. So the current evidence doesn't support a routine dexamethasone in HSV encephalitis, which was consistent with the gas result. But however, the takeover point is dexamethasone can be safely given in any suspected encephalitis without worrying about increased viral replications. Coming to the future directions, definitely dexamethasone is safe. The future studies should explore uh, targeted immunomodulatory therapy rather than non-specific anti-inflammatory like steroids. This is one of the future directions which we have to think of. So we will come to the appraisal summary regarding the strength of this trial. This also we have discussed for the rare disease. It was a first completed adequately powered RCT, uh, and the randomization. They used a minimization randomization with the robust allocation concealment, and then the neuropsychologists were masked for all the primary outcome, for the primary outcome, and they have used a modified intention to treat analysis. Also, the pre-specified sensitive analysis also confirmed the same result as uh, in the modified intention to treat analysis. And then the dexamethasone, there was some safety signal. The dexamethasone was well tolerated. There were no increase in case of viral load. And then they have chosen a disease specific primary outcome, because of which the sample size were 94. They were able to recruit all the patients. And not only that, they also involved Encephalitis International uh, charity, with which they were able to create awareness among the people. So because of which they were able to recruit more people, and then even the last to follow up also within the acceptable range. And then 95% confidence interval reported for all the outcomes at each follow-up visit at 26 weeks and 76 weeks. Coming to the limitations, the again the participants and site teams were unblinded because it was a deliberate pragmatic trade-off to complete the recruitment for this rare disease. And then there was a protocol contamination. Almost 29% of the controls received dexamethasone, even though they did a sensitive, pre-specified sensitive analysis for the primary outcome. They didn't do a sensitive analysis for the secondary outcome. Because of the small sample size, the subgroup analysis were underpowered, and then especially for the imaging and autoimmune analysis were underpowered. And this also we have discussed. The peak inflammatory window is 48 to 72 days. If you see the mean day is they have given the mean 7 days after admission, and then they have the earliest the steroid which they have given is third day. They have never given before the third day. Again, if you see gas trial also, the entry window is less than 5 days. They were not able to complete the trial. So the future trial should look into that early use of the steroids, at least during the peak inflammatory window period, 48 to 72 hours. This is one thing we have to keep in mind. And coming to the autoimmune encephalitis, they have checked only NMDR. They haven't checked the other type of autoimmune encephalitis like a CASP, GABA B, and LGL. That is one thing. And the second thing is the incidence of autoimmune encephalitis only 5% in this trial, but usually the incidence is almost 20 to 25% are expected. Why this is underreported? The reason is they have checked only NMDR, and then they have checked at 2 weeks and also at 26 weeks. But usually the you expect a post HSV encephalitis as at third week to 8th week. So either they were too early at 2 weeks, or they were too late at 26 weeks. That's why they were not able to detect as many cases of a quartomean encephalitis. This also we have to keep in mind. And again, because the adjusted mean differences were wide, which also includes zero, the clinical meaningful benefit or harm cannot be fully excluded. And again, the predominantly white population, and then it cannot be applicable for immunocompromised host and under 19 people. So this is what we have discussed. Most of the boxes they have ticked. Thank you.
Excellent, Dinesh. Excellent presentation. There's hardly any scope for asking you anything. Just one request.
Yes, ma'am.
Can, for all of you actually, whoever is presenting, you should make it a point to put all the figures in and explain. Now, you have explained the result very well. But then
Yes, ma'am.
if you had, instead of putting the table and ticking, you had put each of the Kaplan-Meier graph and each of the tables and explain, it becomes more engaging.
Yes, ma'am.
Yeah, so if you were a participant in that study and you are given the background that this drug was used before, hasn't shown any benefit,
Ma'am.
and you have to enumerate and enlist every possible complication. Despite that, would you have given consent?
Uh, I don't know, ma'am, but I was checking when you asked, like, uh, I,
It's a
I
very
don't have
tricky
answer for.
consent. Do you have in one of your slides any their consent? How did they take that consent?
Uh, no, ma'am, I checked it. I'm not aware. I mean, I'm not aware that how they actually ask for the consent, ma'am. I'm not aware.
In real life, this will be a very catchy situation. What are you going to tell them? May have a future benefit, but to
Ma'am.
you, there is a risk of having side effects, and still you
Ma'am.
must consent. That's a very, very iffy
Well,
statement.
yes, ma'am.
Otherwise, what was, from your point of view, what was most pragmatic about this study?
Uh, ma'am, I mean, the whole point is that since there were no RCTs, they created a local awareness. They tried to complete a study at somehow. So uh, they have done many things. First, the international with the international charity, they try to create awareness at the ground level, and then they were liberalizing in some of the inclusions criteria, and then the coming to the blinded also, there were some liberalization so that they were able to recruit. And then also the disease specific outcome, because even though the mortality was come down with the acyclovir, since still the morbidity remains very high, so they have chosen a disease specific outcome. So, and also the second thing is they have let the clinicians to decide about the dexamethasone even after randomization, even in the control group, if the clinicians feels that dexamethasone can be given, so they have given. It is a kind of reflecting the real world scenario.
Yes, exactly. That was these are the, and the fact that minimization factors were predetermined. It's not
Treat-
that you saw the results and you wanted to say, okay, I see some trend here, I should look into this group. Nothing like that. Everything was well defined. In fact, for everybody listening to this should be saved in your laptop as a poster trial. If you want to conduct a randomization, this is the perfect methodology. Everything needed for the methodology is perfect in this. So it was a very well chosen and very well analyzed. Um, just one word about the post hoc analysis. How have they managed that? What,
Uh,
in your opinion, how have they done that? I mean,
ma'am, no, the thing is, uh, first of all, uh, my question is again, it is a post hoc analysis. That itself is a hype. We cannot take it as a outcome. The second thing is the overall the dexamethasone given the median days 7 days after admission. So the peak inflammatory phase is during a 48 to 72 hours. Uh, uh, Ye- the first of all, the dexamethasone have they have given late. The second thing is, even if they give late also, they have found that the every day of delay in starting the dexamethasone, the verbal memory fell by 5 points, which I'm not able to understand, which I'm not able to correlate pathophysiologically, because uh, if they have given dexamethasone during a second day and third day, then some of the patients for a 7 day, then we can take it as. But they have, in general, they have given dexamethasone late, so I don't know how to interpret this, ma'am. So that is one thing.
Exactly. But it is so eye-catchy, that statement. If they had
Yes,
to
ma'am.
push it further, not
Yes,
saying, I mean, it is very easy to push this as a very big outcome and
yes,
then
ma'am.
say this should be given. But they haven't
Yes,
done
ma'am.
anything of that sort.
Yes,
Very
ma'am.
clearly, they have said this is post-op and there is delay in giving. And
Yes, ma'am.
this is just hypothesis generating is very clearly defined. So
Yes, ma'am.
the overall, the investigators have done a very ethical job.
Yes, ma'am.
It's very pleasing that one of these kind of trials also exist. Deva, you want to speak?
Thanks, ma'am. Dinesh, thank you very much. That was an excellent presentation. Fantastic indeed. Excellent slides as well. Thank you. Just a
Okay.
couple of things, ma'am. For the question you asked, would I consent? Instead of thinking of myself as a patient, I was just thinking of myself as the investigator who approached patients or the families for consenting. Often it's the families that consent initially, right? So when patient is admitted with encephalitis, you approach the families. Clearly, mortality comes down with acyclovir, but morbidity does not. And their hypothesis is giving steroids might affect the morbidity and might improve quality. By improving morbidity, you are indirectly improving the quality of life. And if that is being mentioned, I may be in a position to say yes, go ahead. Yes, you're going to save them, but if this drug might affect the morbidity, why not try it out, is what I would have said. That'll be my answer for that. Both as a as a person that is taking consent, I would have mentioned mortality, morbidity, and improvement in the verbal memory scale. And as a family member also, I would have probably accepted because morbidity is pretty high anyway. So that is one. And the second thing is when we chose the trial, when we looked at the results, we were in double minds as to how to conclude whether giving dexamethasone initially till you get HSV is okay, or give dexamethasone to everybody till you get HSV, and then you decide whether you want to continue or stop, is one kind of conclusion. The other way of concluding is looking at the safety endpoint. In the dexamethasone group, 5 patients developed relapse. I mean, irrespective of what the cause for relapse is, some of them were secondary to autoimmune encephalitis. Although they have not checked all the VGKC, etc., still 5 relapses out of the 41 patients that received steroids, and none in the control group. And that raises eyebrows. So I'm not entirely sure. So we were thinking how to really conclude for us. Maybe I know I'll be in double minds while choosing this drug. And the third point about the post-hoc analysis, it's a median 7 days, and the range is from 1 to 21, as you can see on the slide. So many patients would have received early and patients that have received late, and they compared the two. And clearly, the reason why they did that was in case if there is a future trial, these are things the future trial need to take into consideration. As you both quite rightly mentioned, this is hypothesis generating. So when you design another trial looking at some form of steroids in herpes encephalitis, this is something that you should consider. Now, these are my points, ma'am.
Well taken, Deva. Yeah, I was also expecting emphasis on morbidity reduction for a consent. There is no other way you can convince someone to take it up when you don't have evidence. This happens very regularly when you go with a prospective trial, and not much is there existing in the literature. This is a almost daily occurring problem. Anybody in the listeners want to ask questions? If not, Dinesh, thank you very much. Another very interesting journal club. Thank you. Both of you boys have done exemplary job with journal clubs. The bar is set very high for the next person. Thank you very much. We'll see
Thank you.
next week with our FNCC class. Next time it will be Dr. Vasudha who will be chairing, and they both them would be presenting the topic. Thank you all. See you next week.
Thank you,
Bye.
ma'am.